So welcome everyone to the Bullet Points Lunchtime webinar series on firearm injury prevention for clinicians. My name is Amanda Aubel. I'm a research data analyst at the Bullet Points Project, and I'll be moderating today's session. We're really excited to have our own Dr. Amy Barnhorst here to talk about our newly developed 3A's framework, which was designed to guide clinicians through the process of identifying patients at risk for firearm-related harm and reducing their risk through the selection of appropriate interventions. Before we get started, I just have a couple announcements. Today's webinar is a part of a series that occurs on the third Tuesday of every month at noon Pacific time, where we discuss a different topic in firearm injury prevention in a brief 30 minutes. Throughout the webinar today, please use the Q&A function to ask any questions because the chat feature will be disabled, and we'll address as many questions as time allows at the end of the webinar. We'll also have a quick poll at the beginning and the end of the webinar to help us better understand who's in our audience today and what you learned from this webinar. We really appreciate your participation. So with that, let's launch the opening poll now, and I'll give everyone about 30 seconds or so to answer these questions. Okay, let's close the poll. Thank you everyone for participating. Without further delay, I'm going to introduce today's speaker, Dr. Amy Barnhorst. Amy is the Vice Chair for Community Mental Health at the UC Davis Department of Psychiatry and Behavioral Sciences. In her clinical work, she treats patients with serious mental illness in the emergency department, the county jail, a crisis unit, and an inpatient psychiatric hospital. She's a nationally recognized expert on firearms law and mental illness and studies the interface between firearm violence, suicide, and the mental health system. She works with both state and federal legislators to craft evidence-based firearm laws, and is the director here at the Bullet Points Project, where she's leading the effort in developing and disseminating curricula that teaches healthcare providers how to prevent firearm injuries in their patients. We're so excited to have you here today, Amy, and I'll let you take it away from here.
Thanks, Amanda, for that introduction. And thanks everyone for joining us today. We're excited to roll out the 3A's framework. So this is a framework to help clinicians think through reducing firearm injury in their patients who are at risk. And more about this framework will also be featured in our upcoming continuing education course that is going to be hosted by the California Medical Association for medical CE credits and also by the American Psychological Association for credits for mental health providers. So the goals today for this talk about the 3A's are at the end, you'll understand how to have culturally appropriate and respectful conversations with patients and their families to reduce the risk of firearm injury, and to be able to identify who is actually at risk for firearm-related harm and how to engage with them to reduce their risk, and to be able to describe available interventions for patients who are at risk. So let's dive into what the 3A's are. The 3A's are approach, assess, and act. So these are the 3 steps that someone can take when they're in a clinical situation and have a patient or a client who may be at risk of being injured or killed with a firearm. We're going to go through each of these separately, and you can see that each one actually has 4 components to the A, and we'll talk a little bit about what each of those components mean. So we will start with approach. The 4 components of the approach are to be informed, be respectful, be harm reduction focused, and think about having your interventions and your assessments be individualized. So the approach is really stuff that happens before you walk into the encounter, the exam room, into the clinical appointment, whatever it is. This is sort of the background work you do by learning things, by changing the way you think about things, by framing things in your own head, and how you walk into that encounter with the patient. The first component of approach is to be informed. So we want to have the knowledge to help us understand the situation, our patients, the people we take care of, and the risks of firearms in the home, the benefits of them, and how to have these conversations. So our conversation should be informed on the basics. These include basics about firearms and how they work, what they are, why people own them, the safest way to store guns, and we'll talk about this a little bit later. What are some evidence-based interventions that can actually reduce people's risk of injury? And what are policies that are relevant to your state? So when we get to the part about act, and we talk about things that you may recommend to your patients or interventions that might apply, you want to make sure that those are legal where you work and practice, because there is some variation by state. So being informed about these things, again, you can check out our continuing education course when it comes out. Our website has a lot of information. Many people may already have this background knowledge, but if you don't, you can use some of the many resources at your disposal to be informed. You also want to be respectful. So remember that owning firearms is often closely connected with people's identity. And we should be respectful in our messaging, in our questioning, and be respectful of the role that firearms may play in their life. So a few special considerations for talking to gun owners, keeping in mind that it may be part of their identities, but that these conversations are about reducing access for people at risk, not necessarily about taking firearms out of the home entirely, but how can we keep everyone safe? It also means being respectful of why people own. And many people, most people, 2/3 of owners say that they own to protect themselves from other people. Now, that doesn't completely preclude safe storage or even removing firearms from the home in times of crisis, but it's important to have that perspective and the respect for their reasons for ownership when you work on tailored solutions. And also remembering that sometimes conversations about firearms are political and they are not respectful. And in a clinical setting, politics has no place in these conversations. And if it does come up, that's your chance to redirect the conversation towards the shared goal of reducing risk for your patient or client and the people in their household. So the third component of the approach is to have a harm reduction approach. And this is something we talk about in medicine all the time, the idea that incremental progress is still progress. And whatever may be the absolute best case, if it's not attainable, we have to find something in the middle that reduces some risk, even if not all risk. One example of this is for folks who own firearms to protect themselves and their families. They may want to have them loaded and readily available. The safest thing, if there's somebody in the household at risk, like a small kid, might be to get that firearm out of the house completely. But that may not be reasonable or attainable for that particular family, given their reasons for ownership. And so having a harm reduction approach and being respectful of their reasons for ownership might mean, instead of getting the gun out of the house completely, suggesting something like a quick access biometric lockbox where they could keep the gun inside loaded, but still access it very quickly while keeping it inaccessible to the kid in the home or the other person who's at risk. Again, incremental progress, still progress. And then the last thing is to keep your solutions or your risk reduction to be individualized. So there's rarely a one-size-fits-all solution. And this is why it's really important to be respectful, be neutral, hear about why the person may have firearms in the home, who else is in the home, think about who's at risk, and then really consider tailoring your approach to their unique circumstances of the type, level, and person at risk. So those are the 4 components of approach. Now we're going to go through the next step, which is now you're in the clinical encounter and you're talking to someone and you want to assess, is it relevant to talk to this person about firearms? Now, there may be plenty of people out there, depending on what kind of practice a clinician's in, that for whom it's not relevant to have a conversation about whether or not there are firearms in the home. But there are some situations, many situations, where risk is present. And if somebody has those risk factors, it may be relevant for the safety and health of themselves and or their household to assess their access to guns and their willingness to collaborate on coming up with a solution to reduce the risk of harm. So the first component of assess is to assess for risk factors. And we'll talk about what some of those individual risk factors are. Children and teens in the home are a general risk factor for lots of things, but generally for firearm-related injury as well, because especially with younger children, they can access firearms and often do without parents' knowledge. There are also demographic risk factors for suicide and for violence, both being victimized by it and perpetrating it. But those demographic risk factors are so broad that they're not necessarily useful in a clinical setting. So we're going to talk about the more individual ones. As far as youth and firearms, most firearm suicides among adolescents and also mass shootings, particularly school shootings by teens, are done with a family member's gun. So a gun that they had access to within the household. And as I mentioned, they often have more access than parents and caregivers think. There's some alarming surveys that the parents and caregivers say, oh no, my kid has no idea where the gun is and would never touch it. And when they survey the kids say, oh yeah, I handle the gun. And about a third of firearm owners living with children and teens store all of their guns in the safest way. So what this means is that 2/3 of firearm owners have at least one firearm that is not stored in the safest way with kids in the home. Heavy alcohol use or problematic alcohol use also is associated with both suicide and violence. So one study found that a third of people who died by suicide had alcohol in their systems, but those who used a firearm were more likely to be intoxicated at death compared to those who used less lethal methods. So it seems that there's an association between alcohol and more violent and more lethal methods of suicide. There's also an association between alcohol and violence, and alcohol-related criminal convictions are a strong predictor of future violence, even if the original conviction didn't involve violence. So problematic alcohol use in the home is another risk factor to assess for, as is dementia. One small study in the South found that 35 to 60% of people with dementia live in homes with firearms. And when they have access to firearms, they can put themselves, their family members, and their caregivers at risk. So there's an increased risk of suicide in the early stages of dementia. And then depending on how things progress, people with dementia become confused and sometimes paranoid, and that can put others in the home at risk of being victimized by them. And a firearm in that mix can obviously make things more lethal. One way to approach this is to treat guns like car keys. This is something that maybe the access over time as the disease progresses may have to change. And the last risk factor that we'll talk about assessing for is the presence of intimate partner or domestic violence within the home. About half of female homicide decedents are from incidents of intimate partner violence. And when an abusive partner has access to a gun, the risk of death in that interaction goes up about 5 times. But firearms are not just used to kill people in domestic violence incidents. They're also frequently used to coerce and threaten and terrorize people and leave lasting psychological scars. Domestic violence is also related, as we've seen, to mass shootings, and it's often a precipitating incident for mass shootings. So if you have the sense that somebody who's one of your patients or clients is in a household where there's intimate partner or domestic violence, that again is one of those situations where you want to screen for access to firearms. Even outside of having individualized risk factors, another thing to assess for is ideation or threats. So even if somebody, has nothing we talked about before, but they're saying things like, I want to go into my workplace and kill my boss, or I'm having thoughts about ending my life. If somebody makes those kinds of statements or threats, they should always be taken seriously, and they should always be asked about their access to guns. These statements may come to you directly, but you may hear about them from other parties, such as concerned parents or family members or even employers. If these risk factors or the ideation or threats are present, then the next thing you want to assess for is whether or not this person has access to any firearms. And it's important to normalize this topic and really keep the focus, again, not on anything political or your own personal feelings about having guns in the home, but really keep the focus on risk and safety for the patient or people within the household. Here's an example of one way you can broach these conversations. This pediatrician is saying, I ask all caregivers about things that pose a risk to their families: water heaters, pools, medications, firearms. What steps do you take to reduce access for those who shouldn't have it? And then the last thing to assess for, if you find out that somebody does have risk factors, even if it's just children or teens in the home, and they do have access to firearms, is whether or not they're able or willing to collaborate with you to help choose an intervention or an action that will reduce the risk of firearms in the home. It's always preferable to have a collaborative relationship with the person and work together, maybe even with their family members or their caregivers or the rest of their support system, to work together on solutions, although there may be situations where that's not possible, and we'll talk about those in a minute. So those are the 4 components of, hold on. There we go. Oh, and here's a way you can use some language to assess people's level of collaboration. This is me talking to a patient who I deemed was at risk of suicide. And I said, lots of patients I see have guns at home. Sometimes when someone's going through a hard time, they store their guns away from home, like with a friend or at the gun range or gun store. This is just temporary until they're feeling better. Is this something you'd be willing to consider? So kind of approaching the idea and seeing what they think about working with you to do something collaborative and voluntary. And I use language here like temporary, just to make sure that they're aware that this is something that, they're conceding to and it's only short-lived. So the third A in the 3A's framework is ACT. And ACT is choosing an intervention that is appropriate for the level of risk, the type of risk, and the person or people at risk. So is this a low risk or high risk situation? Is it a risk of violence, a risk of suicide, a risk of unintentional injury, all of the above? And is it the person who's in your office? Is it their kid, their partner, their parent who's living with them, their workplace? Who is it who's actually at risk of firearm-related harm? You can see that on this graphic, it's the most colorful one because the colors denote to some degree the level of risk shown by these various interventions. So we'll talk a little bit about each one, but the blue cooler colors are representing the lowest level of risk, and the higher, warmer colors like red are representing the high level of risk. It's important to think about this if you have somebody who you have assessed is at risk for firearm-related harm and does have access to a firearm, because we know particularly for suicide that one of the most effective ways to reduce the risk of suicide is to put some time and distance between that person and their lethal means. And this is true also for violence, is that when there is a firearm involved in domestic violence incidents or people making threats of mass violence, it's much easier for that person to do harm than if there's not a firearm available. So back to the blue square on the bottom, when nobody is at imminent risk of harm, safe storage is the appropriate recommendation. That's the action that can be taken in almost all cases where somebody does have access to a firearm at home, but no one's at high risk. It's really never the wrong answer. And the goal of safe storage counseling is to just prevent firearm access by individuals who may not be authorized to use the gun, whether they're at high risk because of problematic drinking or domestic violence, or just that they're a 5-year-old kid who shouldn't be able to access the family handgun. So the safest way to store a firearm is unloaded, locked up using a locking device, separate from ammunition, and with the keys and combinations inaccessible to children or others at risk. So a lockbox that your whole family can access the keys to is not keeping that firearm out of the hands of anybody else in the household. Again, with the harm reduction approach, some of these things may not be possible, but having your firearm at least locked up with a locking device with the keys and combinations inaccessible to others at risk, even if it is loaded, is again better than having none of these components. Safe storage devices vary, and depending on the budget and the types and numbers of guns that somebody might want to store and whether or not they want the safe storage option to be portable. There are lock boxes, gun safes, cable locks, and trigger locks. There's more information about this on our website. You can check out our safe storage that talks about some of the advantages and disadvantages of each type. But again, this is part of having that tailored solution that's individualized for your individual patient, so that, depending on what the guns are there for, how quickly they might want to access them, who else is in the household, they may be better suited for a gun safe than a cable lock. And that's part of being informed also, is being able to have those conversations with them. Sometimes that's not enough. And the person who owns the firearms or who would have access to the box or the safe may be the person at risk. And in a little bit higher level of risk time, the firearms might best be removed from home during a time of crisis. And this is called a temporary transfer of firearms. It's a higher risk option, somebody who might be, considering ending their life or having intermittent thoughts about hurting somebody at work, but they're willing to work with you, they have insight, and they're willing to collaborate and remove the firearms from the home. In some places, background checks may be required. In California, in situations where the firearm is being transferred out of the home of somebody who's suicidal, there is a sort of waiver for the background check in that particular situation. But this is one of those things you might want to be informed about your policies in your own state before you make those recommendations. And in some places, temporary voluntary storage is also available at retailers or gun ranges, or even with law enforcement agencies. So those are two actions you can take that are collaborative and where you can work with the patient, but sometimes in really high risk situations where the patient's not willing to or able to collaborate, an emergency intervention may be necessary. So the two emergency interventions we talk about, one is mental health holds. And mental health holds have sort of a specific purpose. They do provide for a temporary separation from lethal means like firearms, and they can connect the person to mental health treatment for any underlying condition that's contributing to their risk. So for example, depression that's contributing to their risk to or psychosis that's contributing to their risk of violence. But this involuntary mental health hold allows for temporary, in California, it allows for temporary removal of a gun only if it's in a person's possession when they're detained. That means like if the police show up at their house and they're actually holding the weapon making threats. If that person goes into a hospital and says, I'm feeling suicidal, and they get put on a mental health hold, they may have a whole gun safe full of firearms at their house, but no one's really going to know about that. And it's not part of the process that somebody would necessarily go get them unless other things happen further down the road. So it's important to know that while a mental health hold can provide a temporary separation between the person and their firearms, it's not going to trigger a prohibition until the patient is admitted to, or in some places actually committed by hearing to the psychiatric hospital. So it doesn't guarantee that after their discharge, they won't have continued access to firearms, especially if it's a short mental health hold with sort of emergency treatment and then they're released. In those situations, you may want to consider an adjunctive civil protective order. And these orders are also appropriate for people who are making threats or having ideation, but may not meet criteria for a mental health hold. So an example is somebody who wants to kill somebody else or hurt somebody at their place of work as an act of revenge that's not due to any kind of mental illness. In those situations, protective orders that can remove that person's access to guns and prohibit them from buying more guns may be the best intervention. But these, again, can also be used adjunctively with mental health holds. Another high risk, another involuntary action people can take in times where they're very, very concerned. There are a number of types of civil protective orders, none of which require any kind of criminal activity to have been committed or require any kind of mental health diagnosis. And depending on the particular situation, you may consider a domestic violence restraining order, an extreme risk protection order known here in California as gun violence restraining orders, a workplace protective order, or school violence protective order. And those all come on some level with firearm prohibitions and removals. So just to recap real quick, firearm violence is a public health problem and clinicians are in a unique position to intervene. And the 3A's provides a framework that can help clinicians remember how to address and reduce risk in clinical settings. And these are, again, the 3A's and the 4 components that go with each one: approach, assess, and act. So that wraps up my part of the talk today. I hope folks have some questions or comments that they can put in the Q&A session. And this is some more information about the Bullet Points Project, where you can find us on email and Twitter and LinkedIn. And I will hand it back over to Amanda.
Thank you, Amy. All right, before we get to the Q&A, we're going to launch our closing poll, and I'll just give a minute to complete that so we can find out what you've learned today. All right, fantastic. Thank you all again for participating. I think to start off, Amy, would you describe a little bit of how the 3A's was developed, why it was developed, and maybe give a little bit of background on where we started and how we got here?
Yeah, that's a great question. So we were working on our continuing education course that I mentioned earlier on, and we just wanted to, I see patients too, and I know how busy clinicians are and how you can get into the exam room and think like, all right, I'm supposed to screen this patient about like smoking. Do they have a carbon monoxide alarm in their home? Are they getting exercise? How are things going with their grandmother? Like there's so much to remember. And, of course, for me, because I do the work I do, I always remember to think through the firearm risk assessment. But it's hard when you don't have a mnemonic for something to just remember what the steps are when you're busy and there's a crisis going on. And so we wanted to come up with something that was sort of an easy, catchy mnemonic that people could remember, even if they couldn't remember all the steps or all the components. They could at least remember there's 3A's and then kind of figure it out from there. And that would be something that would stick in people's heads again, even just as a reminder, oh, right, I should be approaching this patient and assessing their risk for firearm-related injury. And so we just wanted something as a kind of a little earworm that would be in there reminding you to think about this in your clinical encounters, and then help and walk you through, again, at the very least, what the 3A's are, if not every individual component, and then know where to go on the website and look it up.
Yeah, I think it's really important for clinicians to have those mnemonics when there's so much else going on. Also, I'll mention that once our CE course is launched, it goes through these 3A's, but we also have 3 patient case scenarios where we actually show scenarios between a clinician and a patient in different settings using the 3A's to talk through some of these situations. So we think that can also be a great learning opportunity for people who are interested. Another question is about patients' willingness to collaborate. So what might you do if a patient isn't willing to collaborate and let's say they're at high risk or maybe they're at low risk? How do you respond in those situations?
Yes, I think the response is really different, and patients' willingness to collaborate is going to vary. If the patient's not really high risk, say it's somebody who just had a baby and their infant is not currently yet in danger of being able to crawl or toddle around and open, the cupboard that the firearm is in, but that firearm is not stored safely, but the parents are very resistant to talking about it. That may be something that rather than pushing it and losing them completely, you drop it, let it go, hear them out, hear their concerns, and then you bring it back up gently at the next visit. And maybe the following visit, and maybe by the time the kid starts crawling and they get a sense of how much kids get into things, they may be more ready to hear some feedback, to have a conversation, to collaborate on solutions. People who are at very high risk, who are not willing to collaborate, that's where emergency interventions may come in. So somebody who comes in and says, like, I'm absolutely 100% going to go, perpetrate this mass shooting at my whatever, that may be the kind of situation, if you take their threat seriously, where if they're not willing to collaborate, that's unfortunate, but there are other people's lives hanging in the balance here. And something like a civil protective order is going to be, definitely indicated.
Mm-hmm. Great, thank you. And one last question, I know we're at time here, but before we go, for some of those emergency interventions where you might be collaborating with law enforcement or others, are clinicians allowed to disclose information about patients, about risk, or we hear about HIPAA and all of that. So what does a clinician do in those cases?
Yeah, that's a great question, because there's always this concern of like, I'm not supposed to tell any third parties protected health information, right? There's a very specific carve out within HIPAA that if there is a serious and imminent threat of danger, it is okay to disclose that information, protected health information that is relevant to a third party who might be able to lessen the risk. So that might be police, it might be family, it might be the neighbor who's, being threatened. It's not, your friend from college or your sister-in-law, it's somebody who can actually do something about the problem. And so in the situation where a clinician's in a state where they're not able to file, for example, an extreme risk protection order, but the police can, and you think there is a serious and imminent risk, it is okay to call the police and share protected health information with them. And in fact, the HIPAA website goes on to say, and by the way, we are not going to even interpret what serious and imminent threat means. We leave that up to the discretion of the clinician. So they make it very clear that they don't want people not intervening in very high risk situations because of privacy concerns. Great. And that information is actually on our website on the Civil Protective Orders page, if anyone wants a link to the DHS website.
All right, well, we're at time. So I want to thank you, Amy, for your presentation today. Thank you, everyone, for joining us. Please keep an eye out for a follow-up email from us that will have today's webinar recording, as well as information about our next webinar, and when this information about the 3A's will appear on our website, bulletpointsproject.org. Thank you, everyone, and have a wonderful rest of your day.
Thanks for joining us all.
Bye-bye.